Hello and welcome to the Complete Physio podcast. My name's Chris Myers and I'm here today with Yasmin Pelfrey, and we're going to be talking about lateral hip pain. So that's pain on the outside of the hip, and we're going to be talking specifically about something that is called greater trochanteric pain syndrome, which is also known as trochanteric bursitis, but also sometimes called gluteal tendinopathy. Now, I've been a physio for 25 years, and I've never met a physiotherapist that loves treating this condition. Probably one of the reasons for that, as many of you will know if you're suffering with it, that it is actually quite a tricky condition to get better. So where we're going to start today is with terminology, because there are lots of different terms that are used for this condition. So do you just want to do that a little bit, Yasmin?
Yeah, so I guess the term we use now is greater trochanteric pain syndrome, or we can shorten that to GTPS, which is a little bit easier to remember. But previously it's been called lateral hip pain, like you said, gluteal tendinopathy or bursitis. And I think the reason that we have been a bit confused about the terminology is because, there's been some confusion. Things have, originally we thought it might be inflammation at the bursa. And then some studies have shown that there is a tendinopathy at the glute min or glute medius. And sometimes there might even be calcifications or tears at the tendon. So there's a few things that might be going on.
When I qualified 25 years ago, everybody called it a trochanteric bursitis. And as you say, and have alluded to, I think as we found out a little bit more about exactly what's going on with the condition, we've sort of gone slightly away from that bursitis and inflammation, and we probably headed towards this being driven from more of a tendon problem. But then I think we also have that overlap where you have both situations occurring. So who gets this?
So men and women can have the condition, but it is more common in females. So a recent study showed that around 23% of women above the age of 50 might experience these lateral hip pain symptoms.
Incredibly high, isn't it?
Exactly. Yeah. And we think potentially because of the menopause. So it could be women perimenopausal or postmenopausal that experience these symptoms. And this might be because there's a drop in estrogen, which affects the tendon health. And
I think that's probably a really important point, is there seems to be subgroups, doesn't there? And I'm sure the condition is different in as you say, a postmenopausal 50-year-old female to the other sort of group which we see, which could be a male 30-year-old runner or 40-year-old runner. And I think it's naive of us to think there's exactly the same mechanisms going on there. Would you agree with that?
Exactly. The condition is completely multifactorial, which is why it can be tricky to treat, because it might depend on someone's tendon structure, their muscularity, their biomechanics. All of these can interplay, or even the mechanism of injury, for example.
Exactly. And I suppose that's a good point to go on to, is why do we get this? Is it because you fall over, or does it just come on? What do you find?
So this seems to be more of an overload injury. So if we take the example of a runner, it might be increasing their speed or distance, or perhaps changing even the terrain that they're running on, more hill running perhaps. Or it could be something as simple as, in just starting some walking, maybe some power walking. Maybe you decided to get into exercise and you thought, I know what, I'll go for some more walks. And that just gradual increase on load in the hip can cause these symptoms.
Absolutely. So obviously this is one diagnosis for, you can get lots of different problems around the hip, can't you? And I think we were talking earlier, probably around 20% of all hip pain is related to this GTPS. But certainly, and we were talking earlier that I saw a patient that had been treated for about 8 months for GTPS. And quite quickly, I established that this was probably the wrong diagnosis. So what other conditions can, if you like, mimic or overlap with something such as GTPS?
Yeah, I think, really good point, because hip osteoarthritis, patients might experience pain at the lateral side of the hip, as well as maybe referring into the groin. You've also got to think about pathologies that maybe are inside the hip, so intra-articular things like it could be hip dysplasia or a hip impingement. And then also we must not miss low back pain referral. So often that will just refer right into the lateral side of the hip.
Absolutely. I think that's always the difficult thing with our job, isn't it? Patients come in and they say, oh, I'm getting pain in this region. And we know what's underneath that region, but it's not always those local tissues that are causing the pain. Often it's this thing called referred pain, isn't it? And patients often find that very hard to relate to, and I understand, is where you tell them the problem's in their back, but they don't get pain in their back, but it's referring down, and it's quite hard for people to sort of understand that you can have nothing wrong with the area where you're getting the pain, it's just referring down.
Yeah, exactly. And also GTPS can refer down to the knee or even the heel in some cases. So that can also be a little bit confusing, and maybe some clinicians as well might not pick up on that.
So let's go on to that. So where is your if you could just show us, where is your classic location for a GTPS problem?
Yeah, so you're going to experience this right
on the other side.
Right. So you're going to experience this right on the lateral side of the hip. So right over the hip joint.
Like on the bony bit.
On the bony bit,
yeah.
And that will usually be tender to touch. If you lay on that side, it's going to be uncomfortable. That's often where pain is at its worst, when you might wake up in the night with the pain on your hip because of that compression. Stairs are often uncomfortable, walking, running.
Is it worse going up or downstairs, do you find?
Upstairs, yeah.
That's what I find too, upstairs. And you said earlier, and we said about you can get a referral of pain. So a lot of people, you said, will get it here, but just talk to us about where because it does travel down, doesn't it?
Yeah, so...
Or can?
Yeah, it can travel. So you can still experience the pain at the hip, but also be getting it down through the lateral hip towards the knee or even the shin. So this could be confused with an ITB issue or another maybe running injury or even a knee issue. So it's not unusual for that to happen.
Sure. And we talked about the lower back, and one thing we certainly find is if people are getting pins in needles or numbness, that's probably related to something else, isn't it?
Yeah. So that could be the low back, or it could be a neuralgia paresthetica as well.
Yeah, perfect. Okay, so if somebody's sitting at home, they're saying, okay, I think I've got this GTPS or whatever these people keep calling it, and often we call it different things. How are you going to confirm that that's the problem and there's not something else going on?
Yeah. So we are going to need to have a thorough history from you, exactly sort of the onset of when the problem started, what aggravates it. That's going to be really helpful, and that's going to tell us a lot. But then following that, the physio will be able to do a cluster of tests. So there are some special tests that we use. We might get you to stand on one leg. We do a test called a fader test, maybe with a bit of internal rotation resisted, and also palpation. So the therapist should be touching the area. And if that is painful, then we can say it's likely that you've got some lateral.
Absolutely. So what we often get, patients will often ask us, do I need to get an X-ray? Do I need to get an MRI? Do I need to get an ultrasound? What you're saying there is that in the hands of somebody that's seen a lot of this, and it is important that the person that you're seeing has seen a lot of this, that they should be able to get a good idea and be able to diagnose you with this greater trochanteric pain syndrome just from clinical assessment alone. I think that's generally understood. Would you agree with that?
Yes, definitely. That should be something that we can assess in clinic. I think if, there are other concerns, then definitely an MRI or an ultrasound might be appropriate. Or if, you've been having physio for a while and it's not getting better, then definitely imaging should be on the cards.
Yeah, I think up to 80 to 90% of people get better with this problem. But yeah, if you've got to sort of 3 months and things aren't improving, then it might be worth thinking about imaging. Certainly the other people that I think may require imaging is the people where it doesn't fit that classic pattern. So they say, yes, I've got a bit of pain here, but I've got a bit of tingling. Or the classic one is when people come in and they've actually got pain in the groin, because groin pain can often be related to the hip joint. And this lady I saw on Monday, she'd been treated for a lot of many months for pain on the outside, but she kept saying, no, but I also get it in here. And she did the classic C sign where she sort of went in there. And for me, and with the test that I did, I felt that was a more of a hip joint problem. So she is actually going off for an MRI. One thing we talked about before the podcast is the fact that although imaging can be excellent, if we talk specifically about MRI, if you do an MRI of most women between the age of 40 and 60, a significant percentage of them will have a greater trochanteric pain syndrome or a bursitis, but it might not be what's causing their pain. So lots of people can have this on imaging, but actually you see that a lot of the time in people that aren't getting pain. And they have done studies, haven't they, where they've done MRIs of people with no pain, and on imaging they found a bursitis. So it makes it quite tricky, doesn't it? Yeah. Okay, let's go on to the treatment. So let's say somebody's sitting at home, they've got greater trochanteric pain syndrome, and we're pretty confident that's the diagnosis, because that's the first thing, isn't it? Let's make sure that we've got the right diagnosis. How do we treat this?
So first things first, we want to think about education. So if what is causing the compression on that hip, is it your sleeping position? Is it the postures that you're in throughout the day? Are you standing a lot for work and putting a lot of adduction into your hip, which compresses the lateral side of the hip? Or perhaps it's your running pattern.
So crossing your legs like this.
Yeah, crossing your legs like this, not true. And it puts more compressive forces on that side.
What do you mean, just from a layman, because you keep using this word compression, and I understand that, but what do you mean by compression, and how does that relate to the pain?
Guess extra load. So compression is normal. We want to be able to compress things. It's important, for you to run and walk and all of those things. But perhaps it's a little too much, and that's what's aggravating it. And if you've got other things potentially going on around that, maybe your menopausal status, maybe obesity, maybe other dietary or factors, there are lots of things that can contribute to the load on the hip. But it's excessive. So if you're doing something a little too much, it might aggravate it.
So, and is that if it's particularly painful? I'm just thinking, if you've got a patient that only gets pain after 2 hours of walking, and then you've got a patient that's more irritable that maybe gets pain the whole time, does that change the way that you might treat this problem?
Yeah, definitely. So if somebody is more irritable, one, I'll be thinking, yes, about those compressive positions, but sometimes some soft tissue work can be really helpful to offload the side of the hip, maybe working more into the sort of muscle belly around that area, into the lateral hip, because pain makes it, particularly uncomfortable and difficult to do the things that you want to do. Whereas if somebody isn't as aggravated and they're getting their symptoms a little bit later, then the treatment might change. So you might be thinking more that you can load this patient a little bit more in terms of exercise. So you can actually start to maybe strengthen the area around the hip.
Perfect. So that leads us in nicely to sort of a sort of classic question for these, which is, should you stretch it? So if you go online, you're going to see lots of stretches where they're telling people to bring their hips across here, stretch their hamstrings, maybe do like piriformis stretching. So that there's certainly a group of advice out there that would say, well, maybe try and stretch it. And the opposite of that, obviously, is, well, potentially the opposite is to strengthen it, to actually try and strengthen the muscles around it. Do you stretch it? Or do you strengthen it?
Yeah, please don't do lots of stretching or foam rolling or getting a ball in there. It might feel like you're getting the problem, but it actually could make it worse, especially if you're particularly sensitive in that area and your pain levels are high. Essentially it might be applying a bit more compression to the area, making it feel worse. And a lot of people feel like they end up doing that, and then they come with worse.
Yeah, what you find is that patients do it, and the patients love it, don't they? I got that area that really hurt. And actually that, from a brain point of view, is probably going to give them a sensation of relief for a period of time. But what we find is that you're not getting any carryover, so they're not actually improving.
Exactly. And if you might think no pain, no gain, and think that it's a good thing to stretch into it. But yeah, so strengthening it is what we have found to be giving us the best results in terms of rehab. So there was a nice study called the LEAP study. And they
there was lots of people in that study, wasn't there? Or trial. It was
exactly.
A huge...
I can't remember much, but I think maybe 200 something. 200 patients they looked at, and what they found was that they put a group of patients into education and rehab, and they received a sort of heavy loading program, and that they got 3 times a week. So they saw physio twice a week where it was directed, and then they were to do it once at home. And within 8 weeks, there had been sort of a significant improvement in the patient's symptoms.
That's pretty good, isn't it? Yeah. And it's good that that was a big trial and it was well controlled. And I think lots of us will quote that trial because it does support the role of physiotherapy, and obviously we're all biased towards physio. But what I thought was interesting about it is that the idea that you need this supervised rehab. So yes, you can get stuff off the internet, but you might be doing it wrong. You might not be dosing it correctly. You might be doing too much for the stage that you're at. So I think getting good supervised rehab is really important for these. Can you give us a bit more of an idea about the sort of exercises, maybe from that trial or from your experience, that you would use with patients?
Definitely. I think in a really acute stage, I might go for something that's not too heavy on that lateral side of the hip. So maybe some bridges to start with, some isometric hip abduction exercises, along with the education. And then as that starts to improve, I might be looking at loading that a bit heavier. So what that study showed us is that loading the hip or strengthening it through range, so through abduction, was where we got good results. So you could even use a reformer for that. And I think they did in the study, so a Pilates reformer. And you could do that with resistance bands, sort of mid-stage. And then, things like later stage, I might be looking at sort of Bulgarian split squats, more of a return to running program, single leg bridges.
Yeah,
those
absolutely.
Kind of
it depends, doesn't it? Because we've talked about that group that, I've seen Iron men and women with this, and you have to really push them onto that high level exercise. Whereas, a 50-year-old male that really doesn't run but walks around, you don't necessarily have to go to those higher loads. But and the other thing that it sometimes annoys me, but is when patients say, "Oh yeah, just give me the exercise I need to do. Oh, just give me the bit of paper."
Yeah.
And every patient is different. Everybody has different tolerance to load. Everybody is trying to achieve something different, and unfortunately, there just isn't that one set of exercises that just treats everything, is there? You need to see somebody that's going to guide you through, make it specific to what you're trying to achieve as a patient. And that leads us on to that group that we see quite a lot of here, which is where they say, well, I've tried physio and it didn't get it better. Well, what have you tried? Well, I did a couple of stretches. I did a couple of clams, which is that exercise where, I see that exercise seems to aggravate as many as it actually helps. So it's not just a question of, well, I've done a couple of exercises, it didn't help or it made it worse, so I haven't got better with physio, is it? You've got to try more than that.
Yeah, definitely. You should be looking at also strengthening around the hip. So strengthening the quads and the frontal plane, looking at stability. So a lot of the problem around GTPS is maybe moving a bit more, your hip is moving inwards into adduction through maybe more functional movements like going up the stairs or running. So we need to look at rehab around that. So maybe, more squats and step ups, but doing it with correct form, and probably only a physio really can assess what you're doing wrong so that you can then address that.
Yeah, and I find over the years, lots of times people have done like so many abductor exercises, but they've forgotten about the adductor, which is just as important in that stability. And that's what you find, and you've alluded to it there, which is it's that ability to stand on one leg with good stability, because that's what we're doing all the time when we're running, when we're walking upstairs, when we're walking. So you have to have really good stability. So here's not an easy question, but you're the expert. So when do you say physio you're not getting better, physio's not going to help you anymore. When do you say that? After a couple of weeks, 3 months? What's your opinion around that?
I think it's important to be patient with this. This isn't something that is a quick fix. And physio is not a quick fix. It can take months. So, in some cases, they've seen this patient having this problem for 12 months, even up to 2 years even. So I think as long as you're getting good rehab and you're consistent with it, then you will improve. But there are cases where we might also refer you onwards for things like injections or...
Yeah, and we'll definitely come on to that. I think the other thing, and certainly at Complete, our job as physios is to obviously give patient the right diagnosis and give them the right information. The positive thing about this condition in most people, and everybody's is different, if you've got a very irritable problem, then it might be more difficult. But a lot of the time you can keep active and training during your treatment program. It's not the sort of thing where we go, oh, you've got to stop running, you've got to stop going to the gym, because actually that can form part of the treatment, can't it?
Yeah, exactly. General activity is key. It could be cycling, it could be swimming, anything that you enjoy is part of the process as well.
And rest doesn't often help, does it? Like a lot of tendon problems. Okay, so then there's a subgroup. Maybe it's 20%, but we probably see a fair few of them because you often don't see people when they're getting better, do you? Or if they get better. So let's say that they've been to see you, they've done a good 12 weeks of strengthening and there's been some improvement, but they still get a bit of pain when they lie on it at night. They can't get back to whatever it is that they want to be able to do. What's the next stage if they're not improving?
So I think it's important to look at the patient as a whole and not just their hip. So are there other reasons as to why they're not improving? So is there like a hormonal reason for that? Do we need to refer them to their GP or speak with their GP about any hormonal treatment? And then following that, it might be looking at weight loss. So often in some of our patients, that increased BMI is a factor because increased inflammation can affect the tendon health. So that's something to think about. And then also it can be to do with, I guess, thinking about psychological factors as well. And sometimes that also needs to be addressed, mental health. But then we can look at some adjuncts to help us along with our rehab. So Shockwave can be very helpful for patients.
So Shockwave, let's talk a little bit about that, because if you look at, there are some reasonable studies saying that Shockwave therapy, which sounds awful, I always think that people think you're going to put something on their head and reset them. But anyway, so Shockwave therapy is quite popular these days. We do it here. Talk us a little bit. So if somebody's at home thinking, well, I'm not getting better, like, what is shockwave therapy? Who should consider it, and how does it work? 'Cause it sounds pretty scary to me.
It does sound scary, doesn't it? So shockwave is essentially a sound wave or a pressure wave, which is then sort of applied to a tendon, and that can create kinetic energy, which can then help with the healing process. So it might help to sort of increase an pro-inflammatory effect, which can then sort of kickstart healing.
Yeah, absolutely. And we've had some good success with it here. It doesn't help everybody. And what we do find is that if you can do that during the treatment, in the treatment phase, so like whilst they're doing their rehab, that sort of multimodal approach can sometimes help. But at the same time, if you've got a very irritable hip, or if we do think that there's a bursitis in there, then it can sometimes aggravate a bit as well. So should people have imaging? Should they have an MRI before you consider these things?
I think, if you're going to think about shockwave, potentially. I mean, if somebody's got maybe, like you said, bursitis or tears there, or other reasons why it might not be getting better, like potentially calcifications.
Yeah.
So it can be useful, but you don't necessarily need an MRI to shockwave.
No, perfect. And ultrasound can often show these things as well. So that can sometimes be a bit cheaper for people to or a bit easier for people to access. So how many do you have to do? 100 shockwave sessions? Like, how does it fit into a patient's treatment program?
So I think it depends on sort of the chronicity with it. So between 3 and 6 sessions should be appropriate. I wouldn't do any more than that. If a patient's not improving past that, then I think maybe re-looking at the diagnosis and then maybe considering some imaging, because we would think that hopefully that patient might improve with Shockwave and a good rehab program.
Yeah. And with Shockwave, is it something that people get immediate results with? Like, how long do you wait for Shockwave to really start working? What do you find from your experience?
So I think, we still need the healing process to actually do the job with Shockwave, and that can take up to 12 weeks. So you might not get the full results from a Shockwave treatment package until 12 weeks after. But it's great for pain relief as well. So you might notice some changes in your pain levels, but actually maybe changes within the tendon might take a little bit longer.
Yeah. And normally we would use around 3 to 6 sessions, wouldn't we, here? What from my knowledge of the research, what is really positive about Shockwave? First of all, it's non-invasive, so we're not, sticking an injection in, you're not having surgery. But also, from the research, it seems that if you do start improving, you keep improving. And there doesn't seem to be a lot of, unlike injections, which we'll go into, which can give you an amazing result, but it can sometimes or often come back. Shockwave seems to have this nice gradual improvement without that sort of bouncing back. That's from my experience anyway. I think the research would support that. Let's go on to injections. Obviously, I'm quite biased because I do lots of ultrasound guided injections. And so I do see this as a condition quite often. A couple of times this week, I would have injected one of these. And obviously, these are people that are really struggling. And it's the reason they come to see me is because they can't sleep at night and they are pissed off. If you can't sleep at night, it's very stressful. It exaggerates everything, doesn't it? So those are the patients that sometimes I feel can benefit from an injection, which would be a steroid injection in this case. What's your experience of injections, and when do you start thinking about an injection for your patients? Or maybe you don't.
Yeah, so injections can be a useful tool, especially like you said, for pain relief. But it's not my first thing that I'm thinking as soon as a patient comes into my clinic room. I'm trying to settle down the pain conservatively. But it can be, really useful. And I find actually the patients that do seem to improve from it is if there is some bursal involvement. So I think it's picking your patients. So maybe a sort of true tendinopathy, it might not be that useful.
Absolutely, yeah. And I think that's a good point, isn't it? At the point that we often, or I certainly see them, is when they're not getting better and they tried some treatment. And then I think at that point, imaging is really important because one, you want to make sure that we've got the right diagnosis. But also, and this is what you're saying, and I think we totally agree with this, is that you want to know whether it's the tendon that's really, and it's not easy, it's not black and white, but if the tendon's driving it, then you're probably not going to go for a steroid injection. But if it's a bursa, and it's that classic 40 to 60-year-old woman that can't lie on that side, postmenopausal, they seem to do quite well with that. And if it was a tendon problem, that's where I think Shockwave rehab, you have to be really patient with. The other thing I just want to talk about briefly is surgery, because people that have this level of pain for this long, they must think, well, maybe I need surgery. Have you had patients that have had surgery for this, and what's your opinion on that?
So I've had a few patients that have had calcium deposits or calcifications within the tendon.
Where bones in the tendon.
Exactly. Yeah. And those patients might benefit from a barbotage procedure. But for me, that's been quite rare. I'm hoping that most of the patients that I see will do well with rehab and conservative management.
Perfect. Yeah. And I think the only other ones that I've seen that have had surgery is where you've got, and this does happen, where you've got that mixed bag between like a bit of an impingement and hip problem, but they've also got this maybe secondary, because we see a lot of patients that do have a bit of both, and it's sometimes hard to work out what's the primary problem. But I had a patient recently that unfortunately the pain on the outside didn't get better and it didn't change till they sorted, and maybe it was it was all related.
Yeah, exactly.
Perfect. Well, I think we've covered an awful lot. Hopefully people have found that useful. And thanks very much for joining us.
Thank you.